Hi, I'm Chen Chien-Jen, Vice President of Taiwan. I'm an expert in epidemiology, public health, and preventive medicine. Today, I'm going to give you a crash course on how Taiwan is fighting COVID-19. Since 2002, Taiwan has faced a series of novel infectious diseases, including the SARS outbreak of 2003, the 2009 H1N1 flu, and now the 2019 to 2020 COVID-19 pandemic. Taiwan has been prepared for these outbreaks, and we have learned a great deal from them. Here, I want to share some of the things Taiwan has done to contain these outbreaks. The SARS outbreak began in Guangdong, China in November 2002. At the time, we called it atypical pneumonia, but no one understood its causes, symptoms, or how to diagnose and treat it. Our lack of knowledge about the virus caused quite a bit of panic. The first confirmed case of SARS in Taiwan was a business person surnamed Qing who was diagnosed on March 14th. Fortunately, he was treated at National Taiwan University Hospital by Dr. Shang Chun-Zhang, so we were able to prevent intra-hospital transmission. Everyone was very relieved. But in mid-April, Taipei City Hospital's Heping branch experienced an outbreak of intra-hospital transmission, and we initiated a hospital lockdown. The virus began to spread domestically, and at the time, we didn't have reagents for rapid testing or drugs for treatment. Of course, we didn't have a vaccine either. We had no choice but to begin isolation and quarantine to bring the virus under control. Thanks to the concerted efforts of our citizens, we were able to successfully provide isolated treatment for patients and home isolation for those in close contact with infected persons. By July of that year, we had brought SARS under control, and SARS was no longer to be found around the world. This is an interesting phenomenon. In May of 2009, an outbreak of H1N1 influenza occurred in Mexico. Everyone was very nervous about this virus because its mortality rate in Mexico reached 15% at one point. However, we later discovered that when hospitals are extremely busy and unable to provide proper care for patients, the mortality rate increases. Taiwan adopted strong measures to prevent the spread of H1N1 during the 2009 pandemic, including rapid testing and antiviral drugs, which allowed medical practitioners in outpatient clinics to quickly discover and treat patients. Once we had a vaccine, we implemented comprehensive vaccination. We vaccinated more than 25% of Taiwan's population, including more than 75% of elementary and middle school students. After the first wave of the virus ended in May 2010, Taiwan's mortality rate was the third lowest in the world, behind only Japan and Belgium. In June 2012, MERS emerged in the Middle East. MERS is also a coronavirus, so everyone was nervous. However, this coronavirus is mainly transmitted from camels to humans. There was limited human-to-human transmission between close contacts. During the transmission stage, we discovered a unique aspect of MERS. It can be transmitted by asymptomatic carriers. This is very different from SARS, which was only transmitted by those with fevers and very severe symptoms. Now, let's take a look at COVID-19. One important characteristic of this virus is that it can be transmitted by those with mild symptoms as well as asymptomatic carriers. This poses a challenge to our efforts to stop its spread. COVID-19 has taught us that when we don't have vaccines, rapid testing, and antiviral drugs, we need to properly implement isolation and quarantine measures. We are currently doing a good job for implementing isolation and quarantine measures, and I want to thank everyone for their hard work. Taiwan currently has only 373 confirmed cases of COVID-19, and 85% of them are imported. Only 15% are domestic infections, a bit more than 50 cases, and among those, there are only 9 cases for which we have not yet found the source of infection. In other words, Taiwan is experiencing only limited regional transmission, so everyone can rest assured. We have been able to succeed in keeping COVID-19 under control thanks to everyone's hard work. Over the course of this pandemic, everyone has been very concerned about whether COVID-19 has already begun to spread in Taiwan. In epidemiology, we have two major concepts. First, there is local transmission, which means that the patient is infected in their community. Second, there is community spread, which is different. Community spread means that the first wave of infected patients transmits the virus to the second wave to the third wave, and the third wave to the fourth wave. We only label it community spread when the chain of infection is present. Community spread has a number of important characteristics. First, it is impossible to find the source of infection for confirmed cases. As I said earlier, we have only been unable to find the source of infection for 9 out of Taiwan's 373 confirmed cases, and we are still working hard to complete this task. The second important characteristic is that when community spread is present, domestic cases will far outnumber imported cases. As I mentioned earlier, 85% of Taiwan's confirmed cases are imported, so what we are experiencing is local transmission, not community spread. The third characteristic of community spread is the presence of continuous chain of infection. For example, a person returning from abroad infects their family's coworkers, and infects strangers at a convenience store. That is a chain of infection, but most infections in Taiwan have been stopped after one transmission, perhaps at a school, office, or hospital. The transmission does not continue, so we don't have chains of infection. The fourth characteristic of community spread is large-scale cluster infections, which we haven't seen in Taiwan. COVID-19 infections in Taiwan have occurred in communities, homes, schools, workplaces, and hospitals, but there has not been community spread. Not every infected person will experience severe symptoms. We often say that the range of symptoms experienced by patients falls along a spectrum. From healthy to subclinical symptoms, meaning no apparent symptoms, to clinical symptoms, to moderate illness, to severe illness, to death. In reality, these all fall along a continuous spectrum. So how is the population distributed along this spectrum? We can examine most infections using an infection pyramid or infection iceberg. Most severe illnesses and deaths that we see are just the tip of an iceberg. Most people experience only moderate or slight symptoms, and they may even be asymptomatic. As I mentioned before, this complicates our efforts to contain COVID-19. Because even if we send symptomatic patients to the hospital for isolated treatment and quarantine close contacts at home, those close contacts could have been infecting others before they began showing symptoms. This presents a challenge. That is why we have asked close contacts who are in home isolation or home quarantine, or those who are monitoring their own health, to wear face masks, because you might spread the virus to others before you show any symptoms. Family members should also wash their hands often, wear face masks, and maintain proper hygiene. This way, we can stop this virus in its tracks. I want everyone to understand that COVID-19 is different than SARS. The rule for SARS was no fever, no transmission, but COVID-19 can be transmitted by those showing little to no symptoms. So everyone needs to take good care of their health and make a habit of washing their hands regularly and wearing face masks. When necessary, please see a doctor and remember to tell them if you are a close contact of someone infected, or if you are at higher risk of infection. This way we can prevent the virus from spreading within our communities. As I said earlier, we do not have antiviral drugs or vaccines to combat COVID-19 yet, so the most effective way to fight this virus is isolation and quarantine. Are isolation and quarantine really effective? A while back, my grandson was at our house and he said, "Grandpa, does isolation really work?" I said, "Let's do some quick math. If a SARS patient will transmit the virus to 3 of their close contacts, then every transmission is from 1 person to 3 people, 3 people to 9 people, 9 people to 27 people. Then I asked him, if the virus continues to spread this way, how many people would be infected after 10 rounds of transmission? My grandson was stumped by that one. He asked, "How do I figure that out?" He wrote out the problem and realized that nearly 60,000 people would be infected. After just 10 rounds of transmission, nearly 60,000 people would be infected. This is what we call the basic reproduction number, or R0. When R0 is 3, nearly 60,000 people would be infected after 10 rounds of transmission. Then I asked him, what if one of the 3 people infected was isolated or quarantined at home and didn't pass the virus on to others? Then R0 would become 2, meaning that transmission would go from 1 to 2 to 4 to 8 to 16. Then I asked, what would happen after 10 rounds of transmission? My grandson said, 1,024 people would be infected. That's great. See? When R0 drops from 3 to 2, the number of people infected by the virus decreases from 60,000 to 1,000. Then I asked him, what if 2 of the 3 people infected are isolated or quarantined at home, and the virus is only passed on to 1 person? What would happen then? My grandson laughed and said, Grandpa, you're silly. Each person will only spread the virus to 1 other person. After 10 rounds of transmission, the number is still 1. That's how it works. When we implement quarantine and isolation, the virus won't continue to spread. Then I asked him, what would happen if all 3 of them were isolated or quarantined? He laughed again and said, you're so silly, then nobody would be infected. That's how it works. Approaching the problem from the perspective of transmission dynamics, if we isolate and quarantine infected patients, we can greatly slow the spread of the virus and even end it completely. So even though we don't have antiviral drugs or vaccines, we can still work together on thoroughly implement isolation and quarantine measures and take care of our own health so that we can keep the outbreak under control. Now I'm going to use a simple graph to explain. In this graph, we have a small community of 200 people. Now let's assume that this community has an effective contact rate of 0.02. In other words, multiply 200 by 0.02, meaning R0 is 4. We can see that the curve rises sharply and falls quickly. At the end of the outbreak, 7 rounds of transmission have occurred, and everyone has been infected. Only 3 uninfected people remain. In other words, nearly all of the 200 members of this community are infected. Now, we come to this middle graph. When the infection rate is 0.01, meaning R0 is 2, we can see that the outbreak only ends after 13 rounds of transmission. At the end of the outbreak, 38 of the 200 members of the community remain uninfected. If we reduce the effective contact rate once more through isolation and quarantine to 0.005, meaning that R0 is equal to 200 times 0.005, or 1, you can see that the virus continues to spread. Even after 30 rounds of transmission, the virus is still present. But after 30 rounds of transmission, we can see that of the 200 members of the community, 170 have not been infected. This teaches us an important lesson. When R0 is large, meaning the contact rate is high, when we don't implement isolation and social distancing, the curve rises and falls sharply. When this happens, if a large number of people get sick and go to the hospital at the same time, hospitals are unable to provide proper care for them, both in regard to resources and manpower. This kind of explosive outbreak is currently taking place in Europe and the United States. If we can keep the outbreak under control and slow down its spread, then the number of infected patients will remain small, and we can care for them well at the hospital. This will lower the mortality rate as well. So here, I want everyone to understand that R0 is very important. This curve tells us that by implementing isolation and quarantine measures, we can keep the outbreak under control. We can bring this peak down, which is known as flattening the curve. This way, we have a chance to offer the best medical care to every patient. During an outbreak, social distancing is very important. When we maintain social distance, we can lower the effective contact rate I just mentioned. When the effective contact rate is lowered, the disease won't be able to spread quickly. I'll use this graphic to show you. In the beginning, many people are infected, but if enough people can stay home, we notice that the number of infections begins to decrease. So if we stop taking flights, stop going out to barbecue restaurants, and stop hosting large gatherings, we can reduce the number of infections even more. If some people are able to work from home, then we can see that the number of infections decreases even more. There are many ways to increase social distance, like treating infected patients in isolation. This is, of course, very effective. When the number of infections is low, they represent a small portion of the population. Even if 100% of these patients' social activities are restricted, it does not have a large effect on society as a whole. Home isolation and quarantine are helpful, but we need to place even greater limits on social activities people are engaging in. We can close schools because if we close schools, we can reduce the social activities of students and teachers by 50%. Students and teachers make up 20% of our nation's population, so we can see that closing schools lowers the R value from 1.4 to 3.8 to 1.2 to 3.2. This helps, but not a lot. But if we avoid social gatherings and 50% of people limit 80% of their social activities, we can see that the R value falls to 0.7 to 2.0. This means that we can keep the outbreak under control. Of course, there is another way, and that is to completely prevent people from leaving the house. Many cities around the world are implementing this strategy. Under this strategy, 90% of the social activities of 90% of people may be restricted. The R value under this strategy drops to 0.2 to 0.4. In other words, when R is less than 1, the virus won't spread, and the outbreak can be brought under control more effectively. However, completely restricting all social activities will also impact the economy. So we have to think about how to maintain the proper amount of social distance. But I want to remind everyone that if 50% of people limit their social activities to 50% of their regular levels, we can keep this outbreak under control. So I want to ask that everyone keep working to limit their social activities and maintain social distance so we can prevent the spread of COVID-19. Recently, many people have been discussing whether we should be testing the entire population for COVID-19. The main purpose of testing is to find infected people. Then what indicators do we look at to determine if someone has been infected and how well the test works? Of course, our diagnostic tools need to be accurate. We are using the best testing methods in the world. Almost everywhere in the world is using RT-PCR, so we know this tool works. Are we doing enough testing? Let's look at this chart. In this chart, we can see that the UAE and Russia are doing the most testing. Both countries have tested more than 120,000 people. We've tested 20,000 people in Taiwan. Let's look at the positive test rate. The UAE is 0.8 per thousand. Russia is 1.2 per thousand. Taiwan is 5 per thousand. In other words, for every 200 tests run in Taiwan, 1 returns positive. Everyone is saying South Korea is doing well and we should try to learn from their strategy. Indeed, we can see from this chart that South Korea has tested 300,000 people. That's quite a lot. But 8,565 of those people have tested positive. In other words, many people have been infected. The positive test rate in South Korea is 28 per thousand. This is 5.4 times greater than Taiwan's positive test rate. In other words, for every 200 tests in Taiwan, 1 comes back positive. while in South Korea, there is one positive result for every 36 tests run. So why is South Korea testing so many people? They need to test a lot of people because they have a lot of infections. Then why is Taiwan not running as many tests? There are few infected people in Taiwan, so we don't need to run many tests. But when we examine the positive test rate, we can see that Taiwan's testing coverage is much better than South Korea's. In France, there are 167 infected people per 1,000 tested, and in Italy, that number is 200 per 1,000. In other words, they are only testing those who are already showing obvious symptoms. Taiwan is testing many people who aren't showing symptoms, meaning that we are even testing uninfected people. Taiwan's testing coverage is relatively good compared to the rest of the world. We're third, behind only the UAE and Russia. Our testing plan is cost-effective and suitable for our current situation. Recently, a lot of people have been discussing COVID-19's case fatality rate. What is the case fatality rate? The case fatality rate is the number of people who die per 100 patients. If we look at current global statistics, the case fatality rate is approximately 5.5%, but in some countries, the rate is higher, while in other countries, the rate is lower. Does that mean that the virus is more deadly in countries where the case fatality rate is high? Or does it mean that these countries are not taking good care of their patients, resulting in a higher case fatality rate? Or, in other words, are they only testing seriously ill people? If we only test people with slight symptoms, then many of our confirmed cases will be minor cases. Naturally, the case fatality rate will be low. Let's look at another chart. In the countries we just discussed, we can see that Italy has 10,149 cases and a population of 60,048,000. That means their incidence rate is high, nearly 17 per 100,000. There have been 631 deaths in Italy. In other words, 631 out of 10,149 people have died, for a case fatality rate of 6.2%. It seems like the case fatality rate is particularly high in Italy. Now let's look at Singapore. Among 166 confirmed cases, Singapore has not seen any death as of March 11th. They have a very low case fatality rate. Does that mean Singapore has better healthcare and Italy's healthcare is worse? It is possible that because Italy has more infected patients, they are unable to give proper care to patients in the hospital. But there is an even more important cause for this difference. It is possible that Singapore has tested more minor cases, while Italy is testing people who are seriously ill, causing their case fatality rate to differ greatly. We can get an even better picture of this on the next slide. Let's look at the case fatality rate among different countries according to how serious their cases are. Let's look at serious, minor, and mild cases in countries A, B, and C. In country A, 800 people are seriously ill, while 200 people are experiencing minor illness. In country B, 200 people are seriously ill, while 800 people are experiencing minor illness. In country C, 100 people are seriously ill, 600 people are experiencing minor illness, and 300 people have mild symptoms. Let's assume the case fatality rate across all three countries is 5% for serious cases, 0.5% for minor cases, and 0.1% for mild cases. We can see that in country A, 40 seriously ill people and 1 minorly ill person would die, for a total of 41 deaths. In other words, 41 out of every 1,000 people would die. The case fatality rates for serious, minor, and mild cases are all the same as country A, but the distribution of cases is different in country B. There were fewer fatalities among serious cases, only 10. There were more fatalities among minor cases at 4. So we can see that the case fatality rate in country B is 14 per 1,000. Country C is the same. There are even fewer serious cases, so only 5 patients died. There are more minor cases, so there were 3 fatalities. There wasn't a single fatality among mild cases. Thus, country C's case fatality rate is 8 per 1,000. The case fatality rate for serious, minor, and mild cases is the exact same in all 3 countries, but because different levels of testing lead some countries to only test serious cases, some countries to test more minor cases, and some countries to test more mild cases. They all have very different case fatality rates. Armed with this knowledge, it's easier to understand that when looking at case fatality rates in different countries, we need to examine where they are concentrating tests. I want to talk a little about testing in Taiwan. We've said that there has only been 1 infected person for every 200 people tested. In other words, many of the people we've tested are asymptomatic or have slight symptoms. The number of tests we've performed and the coverage of our testing are both highly ranked in the world. We just discussed positive test rates, as well as incidence rates and case fatality rates. Now, let's combine all these statistics into one chart to get a clearer look. In this chart, we can see that in the UAE, the positive test rate per 1,000 tests is 0.8. The incidence rate per 100,000 people is 1.2, and the case fatality rate per 100 patients is 0, because at the time, the UAE did not have any fatalities. Now let's take a look at Italy. Italy's positive test rate per 1,000 tests is 203, while the incidence rate per 100,000 people is 68, and the case fatality rate per 100 patients is 8.3. This chart clearly shows us that the positive test rate varies greatly according to the coverage of the testing performed. The positive test rate per 1,000 tests changes from 0.8 to 200. The incidence rate per 100,000 people changes from 0.14 to 68, and the case fatality rate per 100 cases changes from 0 to 8.3%. These statistics can also show us what effect testing has on these numbers. Let's look at the next graphic. In the next graphic, the x-axis represents the positive test rate per every 1,000 people tested. The y-axis represents COVID-19's incidence rate. Of course, the higher the positive test rate, the higher the incidence rate. We can see that there is a high correlation coefficient between the positive test rates and the incidence rate, meaning they are strongly correlated. We can see that Italy has both a high positive test rate and a high incidence rate. Russia has a low positive test rate and a low incidence rate. More interestingly, we can see that South Korea, Belgium, and France have the same incidence rate, but they have different positive test rates. This tells us one thing. Why is South Korea's positive test rate so low? Because many of the people they tested weren't infected. Belgium is in the middle, which means that some of the people Belgium tested were infected and some weren't. France's positive test rate is even higher, which means that most of France's testing efforts are concentrated on people who are showing symptoms. We can see that even though there is a distinct correlation between the positive test rate and the incidence rate, when countries with the same incidence rate have different positive test rates, that means the coverage of their testing is different. What about Taiwan? We can see in that Taiwan is fairly low in this graphic. We have a low incidence rate and a low positive test rate. That means that although we don't have many cases, we're still testing a lot of people. That's why our positive test rate is low. Now let's look at another graphic. This one is worth taking a closer look at. Will countries with more infected people have a higher death rate? Take a guess. The answer, surprisingly, is that these are unrelated. Let's take a look at the graphic. The x-axis represents COVID-19's incidence rate. The y-axis represents COVID-19's case fatality rate. Looking at this graphic, we can see countries like Italy have a high incidence rate and a high case fatality rate. It looks like there might be something there. But then we take a look at other countries and realize this isn't the case. Let me give an example. The UK's incidence rate isn't high, but its case fatality rate is quite high. It's very possible that the cases covered in the incidence rate statistics are all very serious cases. When we take a look at Taiwan, we can see that the case fatality and incidence rates are both low. Under these circumstances, because most cases in Taiwan are imported, and we are able to trace the source of infection for most local cases, we don't need to undertake comprehensive testing. Performing comprehensive testing may cause us to miss the bigger picture. What we should be doing is testing high-risk groups, close contacts, those returning from affected areas, healthcare workers, bus and taxi drivers, and convenience store clerks are all at a higher risk of being infected. If we want to perform testing, we should concentrate our tests on these people so that testing can truly be effective and we can better protect higher risk people. The average citizen doesn't need to worry because your risk of infection is very low, and those who are infected in Taiwan are being treated in isolation at the hospital. Those who might possibly be carrying the virus are all under home isolation and quarantine, so the virus has essentially been isolated. Thus, there's not much risk that you will be infected. Some people might say, but there are still people who are asymptomatic. But asymptomatic people carrying the virus who are close contacts of infected patients or have recently returned from affected areas are all in home quarantine. Everyone can rest assured. We should be vigilant, but we shouldn't be afraid. We should try to keep calm and go about our lives as normal. We should also wash our hands regularly, have our temperature taken, and wear a face mask when necessary. By practicing good hygiene, we can keep ourselves safe from the virus.